Hello?
You're lagging a bit, Prof.
Hello? Can you all start?
Okay, Prof. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good evening. I bid to our supervisor and also our mentor, Prof. Nora, and to all my fellow friends. So today, our group 1B, we will be presenting about anxiety disorders, post-traumatic stress disorder, and also acute stress disorder. So this is the outline for our seminar today. So we will begin the first topic, which is the separation anxiety disorder. Okay, so separation anxiety disorder, it is defined as excessive worry and fear about being apart from family members or individuals to whom a child is most attached. And also the child may experience fear being lost from their family, and also fear something bad may happen to a family member if they is separated from them. Okay, so regarding the epidemiology of separation anxiety disorder, so it is most prevalent anxiety disorder in children younger than 12 years old, and the prevalence apparently decreases from childhood to adolescent and also adulthood. So yeah, so it is most prevalent for children. And on clinical sampling, it is equally common in males, equally common in males and females. But however, in community setting, it is female is much more prevalent to have separation anxiety disorder. So this is the diagnostic criteria by DSM-5 regarding the separation anxiety disorder, which is the first one is developmentally inappropriate and excessive fear or anxiety concerning separation from those to whom individual is attached, as evidenced by at least 3 of the following. So we can see that there's a excessive distress when there's a separation from home, and excessive worry about losing the attached person, and they will have repeated nightmare involving theme of separation, and they will also have complaints of physical symptoms such as headache, stomach ache, nausea, and also vomiting when there's a separation from attached person. As you guys can see, there's mentioned a lot regarding persistent. So how persistent is considered persistent? So the fear, anxiety, and also avoidance is persistent, usually lasting at least 4 weeks in children and adolescents. And for adults, it is typically 6 months and above. And the next criteria would be this disturbance causes a clinically significant distress or impairment in the social, academic, occupational, or other important areas of functioning. And the next criteria is the disturbance is not better explained by any other mental disorder. So we need to rule out any other mental disorder. Okay, so this is the clinical manifestations of separation anxiety disorder, which the patient may experience unrealistic and recurrent worries about harm occurring to the loved ones. And they may be reluctant to fall asleep without being near to the primary attachment figure. And the patient may also have excessive distress, which examples is tantrums, where there's an ongoing separation, and they may experience nightmares, homesickness, and also all of these physical symptoms which I've mentioned before. So this is the differential diagnosis that we need to rule out for separation anxiety disorder, which includes generalized anxiety disorder, panic disorder, agoraphobia, social anxiety, PTSD, and also depressive and bipolar disorders. So the treatment for separation anxiety disorder, it can be further divided into pharmacological and also non-pharmacological. For non-pharmacological, it is include there's a cognitive therapy, psychological therapy, social therapy, and also relaxation techniques. So for cognitive therapy, it is used to restructure back the child's thoughts and action into a more assertive and adaptive framework in their daily lives, and it also helps the children to be desensitized to the exposure. So example of cognitive therapy would include like modeling therapy, role playing, relaxation technique, and also reward system for any progressive behavior changes. And for social therapies, it is important to tackle any social issues related to the patient, such as like bullying in school. So for pharmacological treatment, we have selective serotonin reuptake inhibitors. Okay, next topic would be selective mutism. So selective mutism is defined as an individual who is not be able to speak aloud in a specific situations when there is an expectation to speak, such as, for example, like in school. So in epidemiology, for selective mutism, the point prevalence of various setting and age ranges from 0.03 to 1%. The prevalence does not vary by any sex or race, and is likely to manifest in young children than in adolescents and adults. So this is the etiology and the risk factors for selective mutism, which the patients may experience a previous stressors before, for example, illness, separation, or patient is abused, neglected, or bullied. So this may be the cause for patient having selective mutism, and also the patient may have underlying language disorder, and these two it may coexist between one another, and the patient may have social anxiety, and the patient may also experience shyness. And the risk factors for selective mutism are divided into temperamental, environmental, and also genetic and physiological according to DSM. For temperamental, which we can see if there's any parental history of shyness, or if the patient had any social isolation or social anxiety. For environmental, we have social inhibition, or maybe in a case of overprotective parents, so that's the risk for the child having selective mutism, and also genetic and physiological part. Okay, next, this is the diagnostic criteria by the DSM-5 for selective mutism, in which it includes first criteria is the consistent failure to speak in a specific social situation in which there is an expectation for speaking despite speaking in other situations. For example, the child may unable to speak during at school, but he or she can speak normally during at home. And the next criteria is the disturbance interferes with educational or occupational achievement or with social communication. And the next criteria would be the duration of this the disturbance would require at least 1 month persist. And the next one is the failure to speak is not attributable to a lack of knowledge or comfortness or associated with the language required in the social situation. And the next criteria would be the disturbance is not better explained by any mental disorder. Okay, so this is one of the clinical manifestation of selective mutism, in which the patient may avoid any social or performance situations such as public speaking or performing in a school play, and the patient may have family history of anxiety disorders before, like social phobia and selective mutism also. Okay, so the differential diagnosis for selective mutism includes communication disorders, autism spectrum disorder, schizophrenia, and also social anxiety disorder. And for the treatment of selective mutism, I think it is mostly the same as separation anxiety disorder before. So I've divided into non-pharmacological and also pharmacological. In non-pharmacological, it includes cognitive behavioral therapy, music therapy, play therapy, and also parent-child interaction therapy. For pharmacological, we have the selective serotonin reuptake inhibitors. I think that's all for my part. Thank you.
All right, moving on. So next we'll be talking about 3 types of phobia. Specific phobia, which I think you guys are much more aware of, and social phobia, and also agoraphobia. So next, without further ado, so we'll be talking about, so what do you think this is? So this is basically people in a festival. So there are some people actually that are quite scared of it. So this is agoraphobia. So what is agoraphobia? Next, so it's the fear of entering open spaces or crowded spaces. So next definition of it specifically is the fear or anxiety regarding places from which escape might be difficult. So this can be in public places, it can be in also closed places. So this is the true definition of agoraphobia, not specifically what people actually think that once you go outside, people are actually scared of going outside. No, this is where places where escape is kind of difficult. You can call it a swimming pool, you can call it in a stadium, you can call it also in public places. So one of the most disabling phobias. It can significantly interfere with the ability to function. So people who are actually scared of actually going outside, so they're unable to function properly. So they're unable to function in terms of work, they're unable to function in terms of social situations outside the home. So the term agoraphobia was actually first described in 1871 to describe the condition of patients who are afraid to venture alone in public places. So they're unable to actually go alone in public places. So the term is from the Greek, so it's fear of the marketplace, because back in the days, the most crowded places are also the marketplace. Next, we move on to the epidemiology. So the lifetime prevalence of agoraphobia is somehow 2 to 6% across studies. So this is taken from DSM. So it's most likely the US data. So according to DSM, people that's age are above 65-year-old have a 0.4% prevalence rate of having agoraphobia. So in many cases, agoraphobia usually comes after or follows a traumatic event in which happened in a public place or in a public setting. So what is the myth actually behind it? So next, so myth behind it is basically when people think I have agoraphobia, which is an anxiety disorder that most people think of fear of leaving your house, when it's actually not right. So agoraphobia is specifically when you're scared of being in a place where the escape is actually hard. So next, so we go on to DSM. So what does DSM actually say? It's marked fear or anxiety if you have 2 or more of the following. So what are the following? So it's using public transportation. So people who are actually scared of going to public transportations like LRT, like the buses, being in open spaces, being in enclosed places, being a closed place, stand in line or being behind the crowd. Some people have this fear or anxiety of staying actually behind the crowd, or being outside the home alone. So if you have 2 or more of the following, you're more likely to have agoraphobia. So B, the next is fears or avoidance is due to thoughts that escape might be difficult or help might not be available. So you might think, in instance, for example, if I'm being in an LRT train, so their escape might be difficult, and also the help might not come actually in the first minutes or in the first hours. Next, usually, like I've mentioned, agoraphobia usually provokes fear or anxiety, meaning that it actually brings you this kind of fear or anxiety of having to be in these places, like open places and closed places. So D, then situations are actively avoided and require the presence of a companion or endured with intense fear or anxiety. So meaning that if you see any of your friends actually trying to avoid all these places, or don't want to actually go alone in these places, they're most likely to have agoraphobia. So next is E, so the fear or anxiety of being out of proportion to the actual danger. F is the fear or anxiety is persistent, so meaning it stays. It doesn't go, for example, just in a week. It doesn't just go in a month, so it usually stays. So the patients will actually tell you that I have this since long time ago, or since quite some time. So they're having for the past years. So it's usually lasting 6 months or more. So it doesn't stay, for example, 1 week, 2 weeks. For example, you have an accident in a public transportation, and then you have some type of fear to go into public transportations for almost 1 month, and then it goes, this is not considered as agoraphobia. And also the fear anxiety avoidance causes clinically significant distress or impairment in the social, occupational, other important areas of functioning, of course. And H, if another medical condition is present, the fear or anxiety is clearly excessive. So if he has another medical condition accompanied with agoraphobia, it might be more vigilant. And of course, the fear anxiety is not explained by the symptoms of itself. And just for I, for example, is not confined to a specific phobia. So for example, if he has an additional phobia with it, for example, he has social anxiety disorder with agoraphobia, this is separate. So you don't actually put it, for example, if you put the patient, you tell the patient that he's unable to actually go to public places to meet people, he doesn't want to meet people, this is most likely social anxiety disorder, not agoraphobia. So we need to dig in deep on why he or she don't want to actually go into public places or enclosed places, or what I've mentioned. So note, diagnosed irrespective of the presence of panic disorder, which will be explained later. If an individual's presentations meets the criteria of panic disorder and agoraphobia, both diagnoses should be assigned respectfully and also separately. So he or she have agoraphobia and also panic disorder. But even if there is a presence of panic disorder due to agoraphobia, it should be treated accordingly. So next, so differential diagnosis. So basically, when you talk about agoraphobia, any differentials in your mind that actually causes anxiety or depression. So it can be MDD, it can be schizophrenia, it can be paranoid personality disorder, avoidant personality disorder, and also dependent personality disorder. So this is differential diagnosis for agoraphobia. Next, moving on to the course and prognosis. So most cases are thought to be caused by a panic disorder itself. When the panic disorder is treated, the agoraphobia often improves by time. So for a rapid and complete reduction, usually behavior therapy is the best. And agoraphobia without a history of panic disorder is kind of incapacitating, meaning that it's going to be there for a long time. And it's often complicated with depressive disorder or alcohol dependence. So meaning that agoraphobia without a panic disorder, you know as a physician that agoraphobia is going to last for a long time. But when we have agoraphobia caused by a panic disorder, this can be improved by time. So what is the treatment for agoraphobia? Next slide. So firstly, we go on to pharmacotherapy. So number one is benzo. So some patients usually use them when faced with the phobic stimulus, meaning that I don't have to use it always. So once I start to have this phobia or agoraphobia in going to public places and I need to go there, that's only when I use benzo. And of course, caution must be exercised when using heavy and dangerous machinery or when driving, especially when first starting the medication or when the dose has been changed. Usually it has a rapid onset and it's commonly prescribed is Xanax and also Ativan. And also it has a potential for dependence. Like I've mentioned, it need to be cautionally used. All right, next is selective serotonin reuptake inhibitors. So this is famous. Why? Because the side effect of SSRI is usually sexual dysfunction, decreased libido, and delayed ejaculation in men, and delayed orgasm in women. So this is the famous side effects of selective serotonin reuptake inhibitors. But usually it's the effectivity is the same as benzo. So it's usually you need to start with lowering the initial dose, then in depression to minimize the initial anxiolytic effect. So it's like steroids. So once you give a dose, you need to taper down. So next is tricyclic and tetracyclic drugs. So this is usually example would be anafrenil, tofrenil, which is also most effective. And doses also can be titrated slowly. Next, which is the second type, which is psychotherapy. So usually you give, next slide. So usually you give pharmacotherapy and also psychotherapy. And it's best if it can involve both. All right. So number one, which is supportive psychotherapy, which involves the use of psychodynamic concepts and a therapeutic alliance. So meaning that you have a person there to talk to about your phobia, and somehow the patients have some kind of adaptive defenses, which are encouraged to be strengthened. So meaning that if you have, if you talk to a patient, you tell the patient that, okay, once you're faced with this situation, what do you do? So this specific thing, for example, what I do usually, he mentioned, for example, I drink lots of water, or usually I try to find something to hold on to. So this way you should encourage them and you should strengthen their adaptive mechanisms of this specific phobia. Next is the insight-oriented psychotherapy. This is where you actually, the goal is actually to increase the patient's development and try to have him manifest the symptomatic behavior, meaning that he should not keep the phobia to himself, and he should tell everyone about the phobia till it actually goes away. So this is what is called insight-oriented, meaning that he's oriented on his medical condition. All right. Next is the behavior therapy. So the behavior therapy is when you have, for example, when you have basic assumption is that change can occur without the development of psychological insight into an underlying cause. So what does that mean? Meaning that you have positive and also negative reinforcements to the patient. So meaning that this is quite interesting, where you actually put the patient in the phobia itself and you see how he reacts. So for example, people who are, you try to sensitize them. So it's called the systemic desensitization. So for example, when you have, for people who are scared of floods, basically you put them in a flood. When people are scared of explosion, you put them in an explosion. So when you have, and you see your response. So once you see the response, you try to actually enhance that specific response in order for the patient to actually desensitize to this specific phobia. So the next one is cognitive therapy. So it's usually similar like behavior therapy, but it's usually done in a short term. And usually it's given as a homework, not like behavior therapy where you actually be there on the field. So in cognitive therapy, usually you give them as a homework and you tell them this task you need to be performed. For example, you need to record yourself in a video that you are staying in a room, for example, enclosed room for 1 hour or 2 hours. So this is the type of homeworks that you need to give to the patient so that himself cognitively he can develop. Next is virtual therapy, which is this is the latest stuff, which is computer programs that has been developed to allow patients to see themselves as avatars. So it's like, I don't know what you call it, like MOBA or PUBG or something like that you see in a crowded place and him reacting inside the game itself. So for example, you put his avatar in a supermarket where there's a lot of people and see how he reacts. This is virtual therapy. It's usually a computer program, which is, this is a new thing. All right, so next, quite an interesting topic. We'll be talking about specific phobia. So some people who have phobia of agoraphobia, we have aerophobia, scared of heights. Some people are scared of clowns. Some people are scared of needles. So this is an interesting topic to discuss. So this is a specific phobia where people themselves have excessive fear of a specific object, circumstance, or a situation. So these three, either an object, circumstance, or situation. So the epidemiology is usually 5 to 10% of the USA population. The lifetime prevalence is around 10%, meaning it stays for people who have this specific phobia, usually 10% of them stays throughout their life. And it's most commonly among women and second most among men. So what are specific phobias? An example. Next slide. Okay, so the 4 major specific phobias, usually natural environment, animals, some kind of medical treatment or mutilation, or situations. So natural phobia, some people are scared of water. Some people are scared of trees. Dendrophobia. Some people are scared of animals, for example, dogs, or equinophobia like horses. And some people are scared of the dentist, we call it dentophobia, needles, trypanophobia, and also blood, hemophobia. And some people are actually scared of situations like aerophobia or claustrophobia, basically being in an enclosed space. So the etiology. Next, okay. So in general, a non-specific tendency to experience the fear on a specific event is usually paired and most likely paired with an emotional experience, meaning that you have an experience of that specific situation, of that specific thing to be scared of. So usually by observing, and usually in terms of modeling, you need to observe the reaction in another and information transfer in which a person is taught or warned about the danger of a specific object. So meaning that you need to actually look into the patient himself and see, are they really scared? You know, because in terms of they're unable to express themselves, they're not unable to express by themselves. So for example, if you pull out a blood in front of the patient, they'll become scared. So this is when you actually try to tell them. And it's usually run in families. So in genetically speaking, it's usually run in families. And studies have also reported that 2/3 to 3/4 have at least one first-degree relative with the same specific phobia. So if your mother, your father have a specific phobia, most likely you'll have the same phobia. So let's go back to DSM. Next. So DSM says
Right. Assalamualaikum.
Walaikum assalam.
Yeah. Sorry, I have to interrupt a bit because of the first from Ahmad Aizat is also there are a few things that we need to discuss a bit and then to clarify. Then after your presentation, we'll give a room for discussion. Yeah. And just
Sure.
before I forget the etiology of specific phobia. Specific phobia is the one that if you have phobia to height, phobia to height, height, or phobia to blood, there's more than hundreds of phobia, more than hundreds of specific phobia. But interestingly, it is a conditioning. This is where the learning theory, the conditioning, the modeling here is the conditioning. So you are conditioned to that phobia. So let's say you have a panic attack when you are the first time that you have you become frightening and panic when you see the mice or maybe some rabbits. Little Albert theory can tell you this about what is a phobia. So what happened is the first time you've got panic or an attack or nervous is when you are in the when you reach when we were shocked by a rabbit. When we touch the rabbit, it's a soft skin. Now, after that, what happened is we associate that condition that rabbit phobia. So we have phobia to rabbits. Sometimes it goes general. We started to have phobia to any furry things. So we probably develop phobia to the cat because the fur. Or maybe we don't want to touch the teddy bear, although it is not real because the fur means phobia. So it can be first a specific condition and later generalized. And this is then we start to avoid. Phobia means anxiety symptoms, avoidance, and relief without that. So if you are having a fear of flight, that flight phobia with a flight naik kapal terbang. So the first time you get it, probably when you are in the flight, you become panic, and then you condition that flight means panic attack, means anxiety, means scary. So we started to develop flight phobia. So when we avoid flight, we are relieved. So this is a phobia. Same thing phobia for social phobia or for the agoraphobia. We probably one time that we got panic or anxious and anxiety or fearful experience is in the crowded places, and we associate that with the phobia to the crowded places or when we are alone in the unfamiliar place. Okay, so that is initiation of phobia, which is conditioning. This is what we can learn from classical conditioning. I hope you still remember the classical when they pair the first the dog salivation with the smell of the food. Then what happened is they pair the smell, the bell, and the food. The food, the bell. So when they give the food, they ring the bell. So the saliva started to show. Then after that, we remove the food. We just ring the bell. So the dog started to saliva as well because it is conditioned. Bell means something. So many of the things that we condition without realizing, we condition ourselves to certain things. Then let's say we have that condition and then now we develop phobia to certain things. Then we avoid that, we get the relief, the reward of relief. This is to maintain the phobia will be maintained because we avoid and we felt relief. So maintaining this through the operant learning conditioning. Because learning can be two. One is operant, one is classical. Okay, I carry on.
Yes, thank you very much, Doctor, for that input. So moving on to DSM-5. So what did actually DSM-5 says about specific phobia? So A, it is the fear or anxiety about a specific object or situation. And usually just noting that in children, usually it's expressed by crying, by tantrums, by freezing, by clenching. So the phobic object or situation almost provokes immediate fear or anxiety. So just like what Prof have mentioned, usually you need to be there in that specific situation to actually have that specific phobia. And C, also mentioned by Prof, is usually actively avoided and usually endured when they think about it or when they actually endure it, comes with intense fear or anxiety, and that's why it's usually actively avoided. D is usually the anxiety and fear is out of proportion by the actual danger posed by the specific. So we as normal individuals, we don't express that fear of anxiety. That's why it's out of proportion. So they're exaggerating it more than a normal actually person. E, the fear anxiety avoidance is persistent, just like agoraphobia, and usually need to last 6 months or more. So that's when you actually mentioned that he has a specific phobia about something. So it needs to last 6 months or more. The fear, anxiety, or avoidance causes clinically significant stress in terms of social, in terms of occupation, in terms of work, and in terms of important areas of functioning as a normal individuals. And the disturbance is not explained by the symptoms of another mental disorder. So this is another thing that we need to note about. So next. Yes, and we need to specify, so we can't say that we have specific phobia only. We need to specify if he or she or the patient know what specific phobia that they might exaggerate intense fear or fears or avoidance. So we need to specify what specific phobia does he or she has. So for example, animal type, is it spiders? Is it insects? Is it dogs? Natural environment, are you phobic because of storms, height, or water? Blood injection like needles or any invasive medical procedure, situational type like elevators, like planes, like enclosed places, or any type of phobia that do not fit in the previous four. So we need to specify what phobia he or she has. So next we move on to the clinical features. So I think most of you guys definitely know that one of the symptoms that the patient might exhibit is severe anxiety of a specific situation or object when anticipate the exposure about that situation or an object. So they will develop severe anxiety. Panic attack, trying to avoid that phobic stimulus because it's already conditioned. That once they be in that specific situation, they're more likely to have this phobic stimulus. They're most likely to have this phobia. And they're trying to avoid that. So they're trying to avoid the phobic stimulus as much as possible. And of course, 1/3 of social phobia might have major depressive disorder. So because of the phobia, they might develop MDD. And also MSE also, like for example, if they have an ego dystonic fear or a specific situation, activity or object, and the patients are able to describe, for example, how they avoid contact with the specific phobia, and also depression. So what is our differential diagnosis? So our differential diagnosis, which is 9 psychiatric medical conditions. For example, if he has a substance abuse, so we say, for example, he has use of substance, particularly hallucinogenic or sympathomimetic substance. Number 2 is CNS tumors. We're talking about tumors in the brain. Number 3 is stroke, for example, all right? And next is psychiatric conditions, differential diagnosis. Number 1 is schizophrenia. What is the difference between schizophrenia and this and specific phobia is that phobia patients have insight into the irrationality of their fears, and usually they lack the bizarre quality of that psychotic symptom. So they don't have psychosis because of that phobia. So this is different between schizophrenia and specific phobia. Third one is panic disorder, agoraphobia, and avoidant personality disorder. So this is similar differential diagnosis like agoraphobia. So in general, usually specific phobia tend to experience anxiety immediately when presented with a phobic stimulus, unlike avoidant personality disorder and agoraphobia. Next is hypochondriasis, which is fear of having the disease, which you can exhibit definitely in a lot of, especially now when people are actually having fear of developing COVID-19. And OCD, obsessive compulsive disorder, paranoid personality disorder, which have generalized fear. So usually paranoid personality disorder, they have generalized fear of everything. So this is the difference between PPD and also specific phobia. The course and prognosis, usually specific phobia exhibits bimodal age of onset, with a childhood peak, for example, of animal phobia and then natural environment phobia, and for example, a blood injection phobia, and early, for example, adulthood develop into other phobia. So they have a peak of onset. And the epidemiological data is not that available that much to actually have a chart. For example, limitation information suggests that the most specific phobia usually begins in childhood and then persists in adulthood, and it will continue to persist. The severity of the condition is believed to remain relatively constant. So we're talking about specific phobia. That's why it will remain relatively constant. And we just like we've mentioned earlier, is that it needs to be 6 months and above to actually say that they have specific phobia. So next. All right, next, treatment. So the first treatment is behavior therapy. So I think I've mentioned it just now, is that behavior therapy, they will use systemic desensitization. So what is the phobia that you have? So you bring the phobia to them to actually try to desensitize them because of this specific condition. So just like what Prof have mentioned, similar with the dog, where you bring the bell, you bring, for example, the saliva, and you bring the food. So you're trying to actually desensitize them from the specific phobia. All right, so the best success of behavior therapy is, number 1, they need to be committed to this specific treatment. And the problems and objectives need to be clearly identified. And number 3, they need to have available alternative strategies with coping with the feeling. So for example, if I have phobia from heights or I have a phobia from needle, I have a coping mechanism already at hand to try to cope with that specific feeling. Next is insight-oriented psychotherapy. And I've mentioned it also earlier with the specific phobia, where it enables the patient to understand the origin of the phobia. You explain to them what is the origin of the phobia, what actually causes the phenomena of the secondary gain, and the role of resistance, and enables them to seek healthy ways of dealing with anxiety-provoking stimuli. So it's more into insights, trying to actually dig in deep, go into the roots of why you have this specific phobia and why you should not have it. Next is virtual therapy. And I've explained it also earlier, is that you have a game or you have a computer screen and patient is usually exposed with the phobia in a virtual setting. And other therapeutic modalities, you can have hypnosis and also supportive therapy and also family therapy of that specific phobia. Next, additionally, they might have specific phobia, for example, and you put him into this exposure therapy. So this is also similar with agoraphobia, where you put them in that specific condition, and this is quite similar. Next, we move on to the pharmacological therapy. So what pharmacologically, you can use beta adrenergic receptor antagonists, especially when the phobia is relatively worse and is usually associated with panic attacks. And this will be explained further on the next speaker. All right, so moving on to the next and the last of my part, which is social anxiety disorder, where you have social phobia. So what is the definition of social phobia? Well, you have the fear of social situations. So usually people with social anxiety disorder are fearful of embarrassing themselves in social situations. So they have specific fears about performing specific activities. So I think most of you guys know like the stage fright. So a lot of people are actually quite scared of being in stage or being in front of hundreds and thousands of people. So this is usually called social anxiety disorder. And usually it involves the scrutiny or contact with strangers. So if I know the people that I am presenting to, there's not much fear into it. But once it goes into contact with strangers, that's when this actually comes in. And of course, there's the term social anxiety and also social anxiety disorder. So there's difference between them too from specific phobia. And usually they might have also specific fears into the social anxiety disorder. For example, performing specific activities in front of strangers, like what? Like eating in front of strangers, like speaking in front of others. And they might have this vague experience of embarrassing themselves in front of others. So for example, people don't like to eat in front of themselves. So this is a picture actually showing that. Next, we move on.
Murad, so what is the difference between the person who has social phobia and agoraphobia? Both are involved in the open public spaces. But what is the difference?
I think there's the keyword to it specifically is that they need to be involved with our contact with the scrutiny or with strangers. So there must be people there. But in agoraphobia, it's the environment itself. So it can be in an enclosed place. It can be in an open space. It's not the strangers themselves. So I think once you ask them, what are you actually scared of? They say people or strangers. I might be embarrassing themselves. I might be embarrassing myself in front of strangers. But in agoraphobia, it's the situation or it's the place itself.
So the fear now, very in simple words, agoraphobia is the fear when the escape is impossible.
Yep.
But for the social phobia and social anxiety disorders is when the fear of being scrutinized, being judged by the people. So that is the in simple words, yeah. Okay. Social phobia people or social anxiety prefers to be alone or prefers to be with someone. What do you think?
I think go back to actually the definition itself is they are scared to be scrutinized with strangers. So I do believe that I think they need someone with them, and at the same time they can actually go alone. But the most important thing is that they
don't want people to be with them even the unfamiliar. So it is. They are happy to be alone. I mean, they are loner. I mean, not to be in the public, but compared to social anxiety, sometimes. And sorry, the agoraphobia, they probably want some familiar faces with them when they are alone. When they are alone, they are afraid. But for the social phobia, being alone is not an issue that much because of the fear here. The fear. One is scrutinized and judged, another one is when escape is not possible. Okay, carry on.
All right, thank you, Prof, for the input. So next, we move on to the epidemiology. So the lifetime prevalence is usually 3 to 13% for social anxiety disorder. And just like specific phobia, female are more common than male. And usually the peak onset is usually in the teens. However, it's still common as 5 years and as old as 35. But the peak age onset is usually during teenage life. And for comorbidities, usually social anxiety disorder, they have a history of other anxiety disorder like mood disorder, substance-related disorder, and bulimia nervosa. So they usually have additional comorbidity with them. So what is the cause etiology? So there's two school of thoughts. So there's two basically theories. One is the neurochemical factors and one is the genetic factors. So neurochemical factors is usually performance phobias release more noradrenaline or epinephrine. So both centrally and peripherally, or sensitive to a normal level of adrenergic stimulation. So they have a benchmark, or they have a line of that they should not be exceeding that specific line. So once they exceed it, they'll start to develop this phobia. So that's why people usually say that it's due to dopaminergic dysfunction. Another one is that genetic factors, meaning that it's running in the family. So if you have first-degree relatives, you're three times more likely to be affected if you have a similar family member of experiencing the same condition. So like always, we go back to the DSM, the Bible. Next slide. All right, so number one, so they have a marked fear or anxiety about more than one time. So in social situations, more than one social situation in which the individual is exposed to possible scrutiny by others. So this is the clear definition of it. So children, usually anxiety occur in a peer setting and not just during interaction with adults. This is in children. So children, for example, are scared of other children, and adults are also similar. So B, the individual fears that they will act in a way or show anxiety symptoms that will negatively evaluate and will lead to rejection. So they themselves are experiencing this fear that they might develop fear. So they're experiencing that they might develop, I might actually be showing anxiety symptoms in a stage. I might be showing anxiety symptoms in front of others, and this will lead to rejection also by the strangers. C is the social situations almost always provoke fear or anxiety, meaning that I think this is straightforward, meaning that you need to be in a social situation for the fear or anxiety to actually start to develop into you. And this is usually seen in children, for example, expressed by crying, by tantrums, by freezing, or shrinking or failing to speak in social situations. So they're usually scared of speaking in social situations. D, the social situations are avoided or endured with intense fear or anxiety. This is similar, I think, to the previous that we mentioned with agoraphobia and also specific phobia, is that they try to avoid these social situations. For example, they try to avoid as much as possible because they know that it will develop into fear or anxiety into themselves. And like I've mentioned earlier, the fear of anxiety is out of proportion to the actual threat posed. And usually it's 6 months or more, just like the previous ones. So next, G. So the fear, anxiety, or avoidance causes clinically significant distress or impairment. The fear, anxiety, or avoidance is not attributable to the physiological effects of a substance or other medical conditions. So this is the separate thing. The fear of anxiety is not better explained by the symptoms or other mental disorder. And if another medical condition is present, it's usually unrelated or usually it's excessive. So we need to specify if they're only performance. For example, I can be in a social situations with strangers. I can talk to strangers. I'm not actually scared of them actually negatively telling things about me, but I might be scared of performing in front of them. So this can be also specified. For example, if they have this fear, which restrict them to speak or perform in public. So they have, for example, social anxiety disorder with performance only. So we need to specify. So differential diagnosis. So differential diagnosis, like the previous ones, so it can be agoraphobia, just like what Prof had mentioned. In agoraphobia, is usually comforted by the presence of another person, while so in social anxiety, they prefer to go alone. In panic disorder, usually also in differential, they might have breathlessness, they might have dizziness, the sense of suffocation, and also the fear of dying. And then another differential is avoidant personality disorder, a major depressive disorder, and also schizoid personality disorder. This is schizoid personality disorder where they have a lack of interest in socializing. And this will lead to also the avoidant social behavior, meaning that I don't want to socialize with no one. So this is more likely about schizoid personality disorder. So the course and prognosis. Next slide. All right, so onset is usually in the late childhood or early adolescent. And it's typically chronic, meaning that it can disrupt the life of an individual over many years. And this include in school or academic achievements or interference also with the jobs themselves in terms of social development. So what is the treatment for social anxiety? So I think that like the previous, both psychotherapy and also pharmacotherapy are useful as treatments. So we can start off with the drugs. The drugs is SSRI, just like I mentioned earlier, which is the first line for patients with the more generalized forms. Benzo, which is relatively short or immediate acting, venlafaxine, and also buspiron. So treatment is associated with performance situations. For example, I use this specific drug only when I know that I'm actually going into stage, or only when I know that I'm actually going to have to socialize with strangers. So they use this drug. So they know that they're going to develop phobia in that specific situation. So that's when they actually use this drug. So it's not used after. All right, as for psychotherapy, so cognitive, behavioral, and exposure therapies are also useful in performance situations, meaning that practice makes perfect. So you should go onto stage, you should go and interact with strangers, you should go and socialize with strangers, and by time you'll start, this phobia will also go away. So psychotherapy, also the combination of behavioral and also cognitive methods. It does include cognitive retraining, desensitization, rehearsal during the sessions, and also a range of homework assignments. I think that's about it for me. Prof, would you like to add anything? I think that's about it. So, Prof, if you're with us, please do interrupt us whenever you would like to.
You can hear me, yeah?
Yeah, now we can hear you.
Okay. Thank you. I think what you need to understand about this theory of before that, any question from the class? Or people goes to sleep easily in the afternoon?
Inshallah, no question so far.
Huh? Okay, what about the treatment? Yeah, okay.
Just
You can write down the question in the chat form if you want. Siapa tu?
Samba.
Mana penanyanya boleh buka aku? Wow, 100 lebih.
I have a question because currently we are talking about phobia and the treatment we give. So basically, the phobia, most of it they impact activity kan, activity of function of daily living kan. So for example, if he is a phobia to insects, for example, like cockroaches and so on. So does it necessary to undergo treatment or just
get
because
treatment?
Yeah, because insect is.
If it is not disturbing you,
It's not. It's being.
do you have to live with the insect? No need, right?
No.
So
Unless maybe they have like insects in their workplace or in their home that might affect them always. So maybe treatment is by desensitizing, give them the cockroach itself.
So avoiding, like, so either the treatment is based on what is the sort of phobia. Another thing is if it is interfere with the work life. For instance, I have one patient who has height phobia. So the office suddenly wanted to shift to the maybe 15th floor or something in the high rise building. So she was furious. She can't. She had this anxiety, and we have to write to the office that they are having that sort of issue. However, the office has to do something. That if the office said that you have to move, so we need to desensitize. Okay.
Yes, Prof. We have another question from the chat. Mentioned that we have two questions from the chat. So the first question is, how do we differentiate schizoid and social anxiety disorder?
Wait. Sekejap, ya. Okay.
Yes, okay, Prof. So we have a question.
The question here, what is this question? How can I see this question?
I can read it out. It's mentioned, how do we differentiate schizoid and social anxiety disorder?
Okay. Schizoid is a personality. You just happy to be alone. I mean, you are not a lonely. You are not even lonely, but you are not a loner. You are a loner, but you are happy to be alone, and you don't have the anxiety symptoms even if you are alone. Schizoid is not socializing. Social anxiety is fear of being judged in front of the people. So it's two different things. Huh? Can we treat vasovagal reflex the same way as a specific phobia? Vasovagal reflex is the severe state of anxiousness. All right, and a specific phobia, specific to what? Cannot be phobia to vasovagal, but the vasovagal attack is the one that causing us the anxiety. So how can we treat? Yeah, but when we think about desensitization, there are two. One is flooding, one is systematic desensitization. The flooding is just put the person in that fearful experience immediately at one go. But for the for the systematic desensitization is you exposed to the least stimulus, and then you upgraded the stimulus from, if we have a phobia um, to cockroaches, maybe we just show the leg of the cockroach, and then we increase to the cockroaches, and we put 2 or 3 cockroach. But for all you know that we don't have to stay with cockroaches unless we are working as in the pest control. So we can't work pest control. We have to see cockroaches, right? So how to treat vasovagal? I think the anxiety that they have must be related to something else. Then we can desensitize the attack. Okay. Any other question?
I have a question. Sorry, kau can read.
Abdul
Assalamualaikum.
Aziz.
Can I ask about can the disorder and also phobia happen in simultaneously? I mean, for example, the patient have agoraphobia and at the same time having social anxiety disorder.
Usually we go for which one is more prominent. Because it's two different things, right? You cannot.
Yes.
The fear of being judged, and then the agoraphobia is the escape. Usually we can see that panic disorder with or without agoraphobia. Sometimes the fear of the anxiety. Now if you look at the phobia itself, you can have the anxiety itself. You can have general anxiety or specific anxiety. So under specific phobia, is the specific anxiety. It does shows that you have anxiety towards certain situation, social phobia, agoraphobia, and specific phobia. So this is a specific anxiety. Generalized anxiety is worry about everything, about eating, about food, about the situation. So they are worried. But the phobia is more specific and discrete to one thing. And if we avoid that situation, we must relieve. But generalized anxiety disorder, uh, it is general. It is even trivial things also we get anxious, worry. Okay, Abdulaziz.
All right. Thank you.
Okay, if there is no question, shall we move on?
Okay, Bismillahirrahmanirrahim. Assalamualaikum, and I am Ni Aisha Mali, and inshallah we will proceed with next topic under anxiety disorders, which are panic disorder and generalized anxiety disorder. Okay, first we go to panic disorder. Okay, for definition, according to Kaplan and Saddox, panic disorder is defined as an acute intense attack of anxiety accompanied by feelings of impending doom. The anxiety is characterized by discrete periods of intense fear that can vary from several attacks during one day to only a few attacks during a year. Usually, the panic attack can happen from excitement, physical exertion, sexual activity, or moderate emotional trauma. Normally, it lasts about 10 minutes to half an hour. However, when someone develops multiple panic episodes, they may experience longer duration. Okay, next. For epidemiology, first, the lifetime prevalence of panic disorder is between 1 to 4%. Panic disorder most commonly develops in young adulthood, with the mean age of presentation is about 25 years old, but it can develop at any age. Women are 2 to 3 times more likely to be affected than men. And lastly, the only social factor identified from research as contributing factor to the development of panic disorder is a recent history of divorce or separation. Okay, next for etiology. Okay, the etiology of panic disorder can be classified into two, which are biological factors and psychosocial factor. For biological factor, the panic disorder can be from genetics. Various studies have found that someone with family history, especially first degree relative of panic attack or panic disorder, have higher risk to develop panic disorder. Second, premorbid personality, for example, anxious, worries, low self-esteem, poor coping skill, or perfectionist, they have higher risk to develop panic disorder. Third is biochemical changes. The major neurotransmitter systems that have been involved are serotonin, GABA, noradrenaline, and glutamate. With the increase of serotonin, noradrenaline, and glutamate, it can increase the rate of anxiety in panic disorder. For GABA, as we all know that GABA is considered an inhibitory neurotransmitter. So the reduction of GABA and its transmission, it can elicit the anxiety. Okay, and next is panic-inducing substances, also known as panicogens. It can induce panic attack in most patients. And lastly, the changes in brain structure and function. From structural brain imaging studies, for example, from MRI, the patients with panic disorder have pathological involvement in the temporal lobe. And for functional brain imaging studies, for example, PET scan, the patients with panic disorder have dysregulation of the cerebral blood flow. It is associated with cerebral vasoconstriction, which may result in CNS symptoms such as dizziness. And in peripheral nervous system, the symptoms which include hyperventilation and hypocapnia. Okay, next for psychosocial factor. Patients with panic disorder have a higher incidence of stressful life events in the months before the onset of panic disorder. So the stressful psychological events will produce the neurophysiological changes in the panic disorder. Okay, for example, first is parents. Parents are being overprotective. Next, upbringing environment, for example, chaotic and uncertain environment. Next, the patient might have childhood trauma, for example, emotional, physical, or sexual abuse. From study, it shown that about 60% of women with panic disorder have history of childhood sexual abuse. And next, had history of separation anxiety, as well as had traumatic life events such as loss of loved ones and family, marital, or work problems. Okay, next we go to comorbidities. Among all patients with panic disorders, about 91% have at least one other psychiatric disorder. For example, majority of them have major depressive disorder and also other anxiety disorders. For example, social anxiety disorder or social phobia, specific phobia, and generalized anxiety disorder. Some other patients might have comorbidities, for example, PTSD, OCD, hypochondriasis, or illness anxiety disorder, personality disorders, and substance-related disorders. Okay, next, we move to diagnostic criteria from the SM5. So the first criteria is recurrent unexpected panic attack. So what is panic attack? The panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4 or more of the following symptoms occur. So among the symptoms are first, palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, sensations of shortness of breath or smothering, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or heat sensation, paresthesia, derealization, which is the feelings of unreality, or depersonalization, which is the feeling being detached from oneself. Next is fear of losing control or going crazy. And lastly, fear of dying. Okay, next criteria. Okay, for B, at least one of the attacks has been followed by 1 month or more of one or both of the following. The first one is persistent concern or worry about additional panic attacks or their consequences. For example, losing control, having a heart attack, or going crazy. And second, a significant maladaptive change in behavior related to the attacks. For example, the patient might design a behavior to avoid having panic attacks. For example, avoid from exercise or unfamiliar situations. Okay, next criteria C is the disturbance is not attributable to the physiological effects of a substance, for example, drug abuse or medication, or another medical condition, for example, hyperthyroidism or cardiopulmonary disorders. And lastly, the last criteria is the disturbance is not better explained by another mental disorder. Okay, next we move to differential diagnosis. Okay, the differential diagnosis for a patient with panic disorder includes many medical disorders as well as many psychiatric disorder. For medical disorders, medical condition, the panic disorder must be differentiated from many medical conditions that produce similar symptoms. For example, panic disorder has symptoms of palpitation, pounding heart, sweating, and chest pain, so it might be similar with ACS and arrhythmia. It is also common in panic disorder to have shortness of breath, which is quite similar with acute exacerbation of bronchial asthma as well as COPD. And besides, panic attack also are associated with a variety of endocrinological disorders, including hypo and hypothyroid state and pheochromocytomas. And lastly, episodic hypoglycemia can also occur in panic-like state. Okay, second is the substance or medication-induced anxiety disorder. The first is intoxication, for example, amphetamine, cocaine, or nicotine. And second is withdrawal, for example, withdrawal from alcohol or withdrawal from sedative hypnotic drugs. Okay, and the third one is for mental disorders, psychiatric disorders. Panic attack occur in many anxiety disorders, including agoraphobia, social and specific phobia. Panic may also occur in PTSD, OCD, generalized anxiety disorder, and separation anxiety disorder. So the key to correctly diagnosing panic disorder and to differentiate it from other anxiety disorders is by the documentation of recurrent spontaneous panic attack. The recurrent spontaneous panic attack. Okay, next we move to investigation. Okay, so for investigation, we can classify into three, which are biological, psychosocial, and spiritual. For biological, we can request for first full blood count, to rule out iron deficiency anemia in the case of poor oral intake or loss of appetite. Second, renal profile to identify hydration status and also drug excretion. Third is liver function test as a baseline before start medication. Next, urine toxicology to investigate for any drug intoxication. And next, thyroid function test to rule out hyperthyroid or hypothyroidism state. And lastly is ECG to rule out any cardiac problem. Okay. Next, for psychosocial, we can take collateral history from family, friend, or their clique. And then we can trace the old note so that we can identify if patient has any medical illness or previous psychiatric disorder, what medications that patient taken, or the side effects. And next, we can do home visit to know the social background and assess family support. Next, academic or work report to know about the personal history of the patient. And then we can do assessment of the anxiety and depression using Beck Anxiety Index or Hamilton Anxiety Rating Scale. And lastly, we can assess patient coping mechanism to know the premorbid personality of the patient. And for spiritual, we need to assess KAP, which is knowledge, attitude, practice with regards to religious practice. Okay, then we go to the treatment. So same as investigation, we can divide treatment into biological, psychosocial, and spiritual.
If you have any question, you can write in the chat box, yeah? And
Okay,
I will ask about this panic disorder is very common situation when you see the patient at the workplace, in the clinic. And the presentation of panic must be a fearful experience as well. So it's like they are going to die. So in between the attack, they normally have anticipatory anxiety. Anticipatory anxiety is the anxiety when you get anxiety when you think about the future attack. So the first attack usually acute. I mean, you don't have, you just sit down and sometimes you wake up in the middle of night, or sometimes you just sit in front of the TV, or you can have it when you are waiting for your turn in the line in the in the post office or in the bank. So this is then suddenly you have the palpitation, sweating, all the fearful as if you are going to die. And the thought that comes to you is, am I having a heart attack? Am I having some the panic disorder patient presented with giddiness, choking sensation, the butterfly in the stomach, the gastric pain, and they have palpitation, sweaty, cold sweat, and then they also can present it with severe muscle tension as well, muscle tense, because this is the anxiety will usually result in the muscle tense, the stress. Okay, so then the subsequent attack usually can be anticipatory anxiety, and they start to avoid some situation because it's a fearful. So normally they will go for doctor shopping from one doctors to another. And they have to have panic attack and then recurrent panic attack, or one panic attack but give rise to a fearful experience throughout the month of 1 month or 2 months, so that we can diagnose panic disorder. Okay, carry on.
Okay, for the treatment, first biological. First, we have SSRI, the selective serotonin reuptake inhibitor. For example, paracetamol, citalopram, and escitalopram. It is the first line treatment, and it should be given at small doses initially and titrated up slowly. However, the limitation of SSRI is that the effect delay. It takes place about in 10 to 14 days. Okay. It also has several side effects, for example, nausea and also sexual dysfunction. And second, we have benzodiazepine. The examples are alprazolam, lorazepam, and also clonazepam. The rapid benzodiazepine is the most rapid onset, and it often within the first week. It can be used for long periods without development of tolerance to the anti-panic effects. And after 4 to 12 weeks, it can be slowly tapered, and while the serotonergic drug is continued. And third, we have tricyclic and tetracyclic drugs. Among the tricyclic drugs are clomipramine and imipramine. It is the most effective in the treatment of panic disorder. However, they are less widely used because they generally have more severe adverse effects at higher dosage. And lastly, monoamine oxidase inhibitors, for example, phenelzine and trinyl and it is less likely to cause overstimulation than either SSRI or tricyclic drug, but they may require full dosage for at least 8 to 12 weeks to be effective. So, if patients fail to respond to one class of drug, another class of drug should be tried. and also the combination of SSRI or a tricyclic drug and a benzodiazepine can be tried. Okay, next we go to psychosocial treatment. First is psychoeducation. So the goals for psychoeducation are to transfer information about the illness and also about the medication and provide a safe place for the patient to vent of their any emotional frustration. And second, we have cognitive behavior therapy, CBT. This therapy is to change the negative thought into positive one. For example, patients with panic disorder have tendency to misinterpret the mild bodily sensation as an impending attack, doom, or death. So we need to provide information about panic attacks and explain to the patient that when panic attack occur, they are time limited and not life-threatening. Okay, next we have stress management, relaxation technique, and deep breathing exercise, coping skill mechanism, and social training, as well as family intervention. The family intervention is needed because we can educate the family members for them to be able to detect early warning sign and provide family support. Okay, then we go to spiritual. First, I depend on individual insight and perception. It can include the implementation of religious obligations and understanding the meaning of the act, and also interaction with positive environment. We need to encourage them to mix with good and positive people. So with treatment, most patients will exhibit improvement and they will be much better. Okay, lastly, we go to prognosis. Okay, from long-term follow-up studies, it shows that about 30 to 40% of patients seem to be symptom-free, and about 50% have symptoms that are mild and not to affect their life significantly, and about 10 to 20% will continue to have significant symptoms. So the frequency and severity of the attacks can fluctuate. For example, panic attack can occur several times in a day or less than once a month. Although the patients do not tend to talk about the suicidal ideation, but they are at increased risk of committing suicide. The patients with good premorbid functioning and symptoms of brief duration, they tend to have a good prognosis. Okay, I think that's all for panic disorder.
Okay, so any question from the class? Okay, the panic disorder, apart from the medical treatment, we also can do the psychological, the CBTs, but the one thing that we use in the clinic, normally we say, can we teach them the relaxation and breathing exercise? We teach them the breathing technique, yeah. And then some people can, we have to differentiate whether this is social phobia, panic disorder, agoraphobia. So all these differential diagnosis will be entertained when we clerk the patient. Okay. Okay, we move on to generalized anxiety. Then we can see what is the difference between panic disorder and GAD. Okay.
Okay, then we go to next, which is generalized anxiety disorder. Okay, for definition, generalized anxiety disorder is defined as excessive anxiety and worry about several events or activities for most days during at least a duration of 6 months. The worry is difficult to control and is associated with somatic symptoms, for example, muscle tension, irritability, difficulty sleeping, and restlessness. The anxiety is not focused on features of another disorder. It is not caused by substance use or another general medical condition and does not occur only during a mood or psychiatric disorder. The anxiety is difficult to control, it is distressing and produces impairment in important areas of person's life. Okay, next for epidemiology, it is a common condition. The lifetime prevalence is about 5%. The ratio of women to men with this disorder is about 2 to 1. The onset, this disorder usually has its onset in late adolescence or early adulthood, although the cases are commonly seen in older adults. In anxiety disorder clinics, about 25% of patients have GAD. Okay, next for the etiology, the cause is unknown, but most probably related to biological and psychosocial factors, same as panic disorder. For biological, we have genetic factors, neurotransmitter factors, as well as neuropsychological. For psychosocial, there are two major schools of thought, which are cognitive behavior school and also psychoanalytic school of thought. Okay, for cognitive behavior school of thought, the patients with GAD respond to incorrectly and inaccurately perceived dangers. They also have selective attention to negative details in their life. For psychoanalytic school, of thought, the anxiety is a symptom of unresolved or unconscious conflict that are being explored by the patient. Okay, next for comorbid. From research, it is stated that about 50 to 90% patients with GAD have another mental disorder. The most often another mental disorder that coexist are usually social phobia, specific phobia, panic disorder, depressive disorder, dysthymic disorder, as well as substance-related disorders. Okay, we go to diagnosis. Okay, from DSM-5 diagnostic criteria, for criteria A, GAD has excessive anxiety and worry for at least 6 months, occurring more days than not, about a number of events or activities. So here we can see the difference between GAD and panic disorder, which is panic disorder is a brief duration, and recurrent panic attacks. However, for GAD, it occurs more days than not, and for at least 6 months. Okay, next for criteria B, it is difficult to control the worry. And C, it is associated with 3 or more symptoms, with at least some symptoms having been present for more days than not for the past 6 months. Okay, so among the symptoms are keep up feeling, restlessness, fatigue easily, difficult to concentrate or mind going blank, irritability, muscle tension, and sleep disturbances. Okay, next. Okay, for criteria D, it is about the function. The symptoms cause clinically significant distress and impairment in social, occupational, or other important areas of functioning. And next, for criteria E, we need to exclude any physiological effect of substance or any medical condition. And for criteria F, it is not better explained by another mental disorder. Okay, the examples are below. Okay, next for differential diagnosis. Okay, the medical conditions and substance or medication-related disorders similar to those considered in the differential diagnosis of panic disorder, it also must be considered in the differential diagnosis of GAD. And the common co-occurring anxiety disorders also must be considered, including panic disorder, phobias, PTSD, and OCD. Okay. Next, for investigation, we can divide it into 3, which are biological, psychosocial, and spiritual. Okay, for biological, same as in panic disorder, several lab tests and ECG are required to rule out other medical conditions and as the baseline before we start the medications. And for psychosocial, we can take collateral history from family, friend, and colleague. We can assess the family support, the coping skill, personality trait, and we can assess the anxiety using the BAC Anxiety Index and Hamilton Anxiety Rating Scale. Okay, next for spiritual, we can assess the KAP with regard to religious practice. Okay, next for the treatment, we can classify same as investigation, which is the pharmacotherapy or biological, psychosocial, and spiritual. For biological, first we have benzodiazepine, buspirone, venlafaxine, SSRI, and Tricyclic, and also monoamine oxidase inhibitors. Okay, for psychosocial, first we have CBT. We can teach patients the cognitive and somatic coping skills so that they can manage their anxiety effectively. And second, we have insight-oriented psychotherapy. It is focused on uncovering the unconscious conflict and identify the ego strength of the patient. Next, psychoeducation. It is important to provide knowledge to the patient about the importance of compliance to the drugs, and also educate the patient about the side effects of the drugs. And next is supportive therapy. We can give a reassurance and comfort to the patient. And lastly, about the stress management and relaxation therapy, which is it consists of progressive muscle relaxation and also breathing technique. And the third one is spiritual. We can encourage patients to perform their ritual obligation and understand the meaning behind it. We can inculcate the moral values to the patient, as well as we can encourage them to study of religious or any spiritual material. And lastly, we go to prognosis. So GAD is considered to be potentially chronic illness, and the severity of the symptoms are fluctuating over time. So GAD is associated with a significant degree of functional impairment, similar to that with the major depression. And the clinical cause and prognosis of this disorder are difficult to predict because of high incidence of comorbidities or of other mental disorder in patients with GAD. Okay, these are the references.
Okay, thank you. Thank you. How many more topics that we need to go through?
Two more.
Two more, the PTSD and the acute stress. Is it? Okay. So one thing about I want you all to remember is what is the difference between GAD and panic? Because this is usually most of the people can't differentiate. So the panic is the most prominent symptoms is the panic attack. And in between, they sometimes have mild depressive, mild anxiety symptoms. However, for the GAD is about the prominent symptoms, the worry, free floating anxiety, sometimes got muscle tense here and there, and um, the worry is not just some trivial things. Also, they got worry. So they worry of going to the class, driving, and when they get worried, some of the GAD can have panic attack specifier. So depression can have panic attack specifier. So GAD with sometimes the whole features, the hallmark features is worry, 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 but sometimes they get sometimes to the extent that I am worried about going out to the about eating until I get sometimes some panicky. But for a panic disorder, the first is usually acute. Dia takut sebab panic tu. Kalau GAD is they are anxious about, they worry about many things. So what is, for instance, like if we have a specific phobia, we are worried about specific. So GAD is non-specific. Panic disorder is worry about the panic attack, but the GAD is worry about many things. Sometimes the usual things, trivial things, and we sort of like always feel like we are having anxiety throughout the day, free floating anxiety. Okay, so that's the usual differences. Okay, I think we can manage to stop by 6 the most, yeah, because I think some of us want to break fast, iftar for hari Arafah. Okay, so we can continue if there's no question. Okay.
Bismillahirrahmanirrahim. My name is Fatina Jihad binti Amir. I'm the first presenter for today, and I will continue the presentation with the post-traumatic stress disorder. So this is my outline. For the introduction, PTSD is defined as a long-lasting stress and anxiety response following a traumatic or catastrophic event, which the person experienced or witnessed a traumatic event such as actual or threatened death, such as in war or natural disaster, or a serious injury to oneself or others, or a threat of the personal integrity to oneself or others, such as assault cases, rape, or being kidnapped. So this PTSD is characterized by 3 domains of symptom. The first one is intrusion symptoms, such as having a flashback or dreams. Second, avoiding stimuli associated with the trauma. And the third one is the hyperarousal or increased arousal, such as having insomnia and hypervigilance, which then leads to social, occupational, and interpersonal dysfunction. So for the epidemiology, according to the World Mental Health Survey in 2015, Northern Ireland has the highest lifetime prevalence due to the high trauma exposure. And according to our textbook, Kaplan and Sadat, female has higher lifetime prevalence. And among the Vietnam veterans, about 30% of them having full-blown PTSD, with 22.5% having partial PTSD, which fall just short to qualify into this disorder. Among the types of trauma, sexual relationship violence such as rape or childhood sexual abuse or intimate partner violence, about 33%, and the interpersonal network traumatic experience, about 30%, such as in unexpected death of a loved ones, is the top two leading trauma to cause PTSD. Next is the comorbidity. So PTSD has a high comorbidity rates, with 2/3 of them having at least two other disorders. The common comorbidities are conditions such as depressive disorder, substance-related disorder, anxiety disorder, and bipolar disorder. And this comorbid disorder make person more vulnerable to develop PTSD. Next part is the etiology. So the etiology of causes can be divided into stressor, risk factor, or vulnerability factors, psychodynamic factors, cognitive behavioral factors, and biological factors. So the first one is stressor. Stressor is the prime causative factors in the development of PTSD. However, the stressor alone is not sufficient to cause the disorder, and the response to the traumatic event must involve intense fear or horror. And we must consider the individual's pre-existing biological and psychosocial factors and events that happen before and after the trauma. So, for example, a member in a group who lived through a disaster can sometimes better deal with trauma compared to only one person who lived through a disaster, or we call it the only survivor. So next etiology is the vulnerability. Vulnerability or risk factor of PTSD. So what is the risk factor? The first one is presence of childhood trauma, borderline, paranoid, dependent or antisocial personality disorder traits, and inadequate family or peer support system, being female, genetic vulnerability to psychiatric illness, recent stressful life changes, perception of an external locus of control or natural cause rather than an internal one which caused by human cause, and recent excessive alcohol intake. So next factors is the psychodynamic factors. So it has been hypothesized that trauma has reactivated a previously inactive yet unresolved psychological conflict. So the revival of the childhood trauma result in regression and the use of the defense mechanism of repression, denial, reaction formation, and undoing. So this pre-existing conflict might be symbolically reawakened by the new traumatic event, and the ego relies and tries to master and reduce the anxiety. So next is cognitive behavioral factors. So the affected person cannot process or rationalize the trauma that precipitated the disorder. So this affected person usually avoid using the avoiding technique. And also the affected person also may have alternating periods of acknowledging and blocking the events. So they are basically this model have two phases. The first phase is a trauma, unconditioned stimuli, producing a fear response, and the second phase is the conditioned stimuli, produce the fear response independent of the original unconditioned stimuli, and then the person develop a pattern of avoiding. For example, a victim was sexually abused, sexually assaulted in a bus, and the perpetrator is a tall guy with a blonde hair wearing a black clothes. And the trauma or unconditioned stimuli is the sexual assault, while the conditioned stimulus is the perpetrator characteristic and the place where the assault happened. So the victim is afraid of a tall guy with a blonde hair wearing a black clothes and avoiding to take the bus. So next, we go to the diagnostic criteria for PTSD according to the DSM-5. So the following criteria apply to adult, adolescent, and children older than 6 years old. So we have 8 criteria, criteria A, B, C, D until H. So the first one, the criteria A is the exposure to actual or threatened death, serious injury or sexual violence in one or more of the following ways. The first one is directly whether the patient is the person is directly experiencing it, witnessing it, or it occurred to a close family member or close friends, or it is experienced the repeated or extreme exposure. Next, the criteria B, the presence of one or more of the following intrusion symptom. The keyword is intrusion symptom, such as the first example is recurrent, involuntary, and intrusive distressing memory, or recurring distressing dreams, or the individual feels or acts as either if the traumatic events were recurring, and intense or prolonged psychological distress, or the person have marked physiological reaction. Criteria C. Next. Criteria C is the persistent avoidance of stimuli which associated with the traumatic events beginning after the traumatic events occurred, with the evidence by the avoidance of distressing memory, thoughts, or feeling, or they avoid the external reminders. So next, the criteria D is the negative alteration in cognition and mood. So, for example, the person have an inability to remember, have a persistent and exaggerated negative belief, persistent distorted cognition that leads the individual to blame himself or herself or others. They have a markedly diminished interest, detachment, and persistent inability to experience positive emotion. So next, the criteria E is marked alteration in arousal and reactivity or hyperarousal. So the person is irritable, have an irritable behavior or angry outburst, have a self-destructive behavior, hypervigilance, exaggerated startle response, concentration problems, and sleep disturbance. So for the criteria F, the duration of the disturbance is more than 1 month. Criteria G, the disturbance cause and impairment function. And criteria H, the disturbance is not attributable to the effect of the substance. So next. And also in this diagnostic criteria, we may want to specify whether the PTSD come with the dissociative symptoms such as the depersonalization or derealization. And also, we may want to specify if the PTSD is with delayed expression, if the full diagnostic criteria are not met until at least 6 months after the event. So next, so this is the summary for the diagnostic criteria. You can go for the quick recap. So next, the differential diagnosis. So differential diagnosis of PTSD is the panic disorder, generalized anxiety disorder, major depressive disorder, borderline personality disorder, dissociative disorder, and factitious disorder. So this DDX differential diagnosis can be distinguished from the PTSD by the definition itself, the long-lasting stress and anxiety response following the traumatic events, and the characteristic of the PTSD, the 3 domains, which is the intrusion symptom, avoidance, and hyperarousal. So next, for the cause and prognosis for PTSD. So PTSD may develop after the trauma or may delay after the trauma up to 1 week or until 30 years. And the symptoms fluctuate and become intense during distressing periods. So for the prognosis, good prognosis have rapid onset of symptom, short duration of symptom, which is less than 6 months, good premorbid functioning, strong social support, and absence of medical or psychiatric or substance-related disorder or other risk factor. However, PTSD with poor prognosis, especially in the very young and elderly, because this age group is more difficult to cope, and poor prognosis in PTSD with comorbidities. So next, for the treatment of PTSD can be divided into two, pharmacotherapy and psychotherapy. For the pharmacotherapy, the first line treatment is the selective serotonin reuptake inhibitors such as sertraline and paroxetine. So these selective serotonin reuptake inhibitors will reduce and improve the PTSD symptom. So other pharmacotherapy, we can use the tricyclic antidepressant, monoamine oxidase inhibitor, anticonvulsant, reversible monoamine oxidase inhibitor, antipsychotic, reserved for short-term control of severe aggression or agitation. So next is psychotherapy. So psychotherapy, we have like previous presenter, we also can use a cognitive behavior therapy, CBT, and also we can use the exposure therapy, where the patient re-experience the traumatic event through imaging techniques or in vivo exposure. Also, we have the stress management, which includes the relaxation techniques and cognitive approach to cope with the stress. And also, we have the eye movement desensitization and reprocessing, EMDR, which the patient focus on the lateral movement of the clinician's finger while maintaining a mental image of the trauma experience. Also, we can give the good therapy or family therapy for the psychotherapy for the PTSD. So I think that's it for my part. This is my differences.
Okay, PTSD is the diagnosis what? Okay, can you hear me?
Yes, doctor. Yes, prof.
PTSD can come in terms of when the person meet a disaster, usually. It is extraordinary situation, not the usual stress, a stressor. Usual stressor, fail exam, fail marriage. Some of this life event, it is not called. So it is not called as PTSD. However, if the patient has within 1 month, the patient can have acute stress reaction. So acute stress disorder. After basically PTSD is after 1 month exposure to the disaster or to the extraordinary stressor. But what do we call for those who has a stress and adjustment towards the usual stressor? Change, COVID, semua ni. COVID can be trauma. So let's say PTSD, there will be some avoidance behaviors, hypervigilance state, and then adjustment disorder is the usual normal stressor. That is adjustment. Difficulty to adjust with the new house, new school. So these all are usual. The extraordinary goes into acute stress or PTSD. Within 1 month, acute stress reaction. After 1 month, symptom persist, we call PTSD. Okay. Carry on. Siapa next? Last presenter.
Okay, I will cover the topic on the acute stress disorder. Okay, first, as Prof mentioned that the difference between ASD and PTSD is the duration. So basically, ASD is a psychiatric diagnosis occur in the patient after exposure to the traumatic event or stressful event. So the symptom is similar to the PTSD except to the duration. It is restricted to 3 days till to 1 month, as PTSD is more than 1 month. Okay, next slide. For the epidemiology, ASD affects 14 to 33% of person exposed to the severe trauma. Okay, this statistic is according to the US population. Okay, in US and non-US, higher rate are reported due to the interpersonal traumatic event, including the assault, rape, and witness the mass shooting. As for the less than 20% is not involving the interpersonal assault, such as the MVA and others. Okay, next slide. Okay, for the risk and prognostic factor, the first one is the temperamental, where the risk factor include the prior mental disorder, high level of the negative affectivity, greater perceived severity of traumatic event, and the avoidance coping style. As for the environment, the person may have exposed to traumatic event, as the risk factor is history of prior trauma. And the last one is the genetic and physiological. And for the usually female is more common compared to the male. Okay, next slide. Okay, for the diagnostic criteria, we follow the DSM-5. Okay, the first, it is same like the PTSD, where A is exposure to the actual or threatened death, serious injury, or sexual violation in one or more, as the following. First, the directly experience, witnessing in person, or maybe learning that the event. The fourth is experience repeatedly or extreme exposure to aversive details. Okay, next slide. Okay, for the second criteria is the presence of 9 or more, where I want to highlight that there is 5 category of symptom for ASD is where intrusion symptom, as my friend also mentioned in the PTSD, negative mood dissociation, avoidance, and arousal symptom. Okay, you can read more on the intrusion symptom. Okay, next slide. Okay, for the negative mode, dissociative symptom, and the avoidance symptom. So I think you all can read to understand more for the further understanding. Okay, next slide. Okay, for the arousal symptom also. Okay, then we go to the another criteria where, okay, the another criteria is the duration, where as I mentioned before, for ASD is 3 days till to 1 month after the trauma exposure. Okay, the fourth criteria is the disturbance causes clinically significant distress or impairment in the social, occupational, or other important area of functioning. And the last criteria is that the disturbance is not attributable to the physiological effect of a substance, such as the medication or alcohol or another medical condition. Okay, next slide. Okay, then we go to the treatment, divided into the divided into 3, where we have initial treatment. We give the psychological first aid (PFA), psychotherapy, and pharmacotherapy. Okay, next slide. We go first to the psychological first aid (PFA). Okay, for the PFA, there is 8 points to highlight, where the first one is making contact with and aggregating the patient. The second one, ensuring that the patient's safety and comfort. The third, providing the stabilization. And the fourth, gathering information about current needs and concern. And the fifth, providing the practical assistance with immediate needs and concern. Six, we connect the patient with social and the other type of the support. And 7, we provide information about the stress reaction and how to coping to reduce distress and promote the appropriate coping. And the last one, we link the patient to the collaborative service to emphasize on the using of the local resources to ensure that the service are culturally and regionally appropriate. Okay, next slide. Okay, for the psychotherapy, as mentioned, CBT is one of the therapy we can give for the ASD. Okay, second, we give the CISD, debriefing or critical incident stress debriefing, where this CISB is a version that often part of the multi-component program. Typically, we deliver it in the group setting, uh, setting up 2 to 10 days after the traumatic event. So we provide the educational and the tips on the coping and attempting to the patient's reaction to the trauma, and it's not routinely done. Okay, next slide. Okay, as for the pharmacotherapy, we give only necessary. It depends on the patient needs. Okay, there is evidence we give atypical antipsychotic can treat acute treatment for the ASD, but the exact pharmacotherapy for the ASD is there is insufficient evidence. So the trial
Because of the treatment, usually for the acute stress, post-traumatic, sometimes can be psychotherapy. We do grief work for the losses. We do um, for this acute stress reaction, we debrief the person. The person talk about that event, and pharmacotherapy usually we use a short-term benzodiazepine, such as alprazolam, lorazepam, clonazepam. So all this can be helpful for the patient to regulate their emotion, the anxiety, and then we can use some talking therapy lah, anxiety provoking situation, then desensitize, and the short term and antidepressant, short term of benzodiazepine is useful for the patient who is under grief, under PTSD, or under acute stress. Yeah. Okay.
Okay, then we go to the next slide. So we comes up to the Islamic input. As the previous presenter present on the anxiety, phobia, panic disorder, PTSD or stress. So we need to ponder off on the Islamic input. Okay. In this world, we human beings are tested with different trials from others, from cradle to the grave. So being afflicted with the trials and tribulation is actually a part of this world life event. So there is no one being excluded. So Allah tested us in different way, as keep in mind that Allah will never test us exceed from our capability. So a person will tested according to their level of iman. In Surah Al-Baqarah, verse 155 and 156, and we will surely test you with something of fear and hunger and a loss of wealth and life and fruits, but give good tidings to the patient, who when disaster strike them, say indeed we belong to Allah, and indeed to him we will return. Okay, so our presence in us as human being is test for us from Allah.
Okay. But I think for the anxiety disorders, when we talk about Islamization of human knowledge, not just by IIMP and we take one verse, one surah, we have to think about what are the areas that we can take the surah specifically for the ayat, for specifically for certain things. For instance, here.
Okay, Prof, we go
yeah.
to the another slide.
Mm-hmm.
Where, okay, for as Prof mentioned that for the anxiety and so on. So what we need to is what we read to that particular diseases is that we need to have patience. So in Quran, I was said that when we being tested, so we need to seek help in patience and salah. And truly it's extremely heavy and hard, except for humbly submissive to Allah. And Prophet also said that the real patience is at the first stroke of the calamity. So from this presentation seminar, so I think as the person that being tested with the diseases or anything else, so we need have patience first. So with that patience, we have the clear mind to having another plan in the life. Okay, maybe we go to the last slide. So I just want to share where in verse Quran in Surah Ar-Ra'd, verse 28, verily in the remembrance of Allah do heart find rest. From this we know that when our heart will be find peace when only we remember Allah. By remember Him, our heart will be in peace. So we can do the zikir, and on this blessed day in the Arafah day, where we can make a lot of dua and zikir. So I think that's all from me.
Okay, I thank you for all presents. I just want to highlight on the treatment in the PTSD acute. If you look at that, all encompasses one presentation: anxiety, the worry, the resah, the stressful, the fear. So this is, you can see all this in the acute stress, PTSD, anxiety disorders itself. Because under PTSD you can have anxiety symptoms. So how to make your Islamization or Islamic input much more meaningful is not just share thank you for sharing all those words, but look, for us to be able to understand, when we see a patient, we say, ingatlah Tuhan, nanti hati tenang. This is all the things that they say. I have been praying. I don't feel calm, ease. Of course, we will, like in the beginning, not in the beginning, we will say, let's be patient. Okay, sabar, sabar. What else? That sabar. So the real situation is, let's say, PTSD or acute stress. That is a stressor, a huge stressor. Maybe rape, PTSD, yeah, post trauma, a fear of any kind of man comes nearer. So the fear, sad fear, is being said in many verses as well, and we try to put what happened in the Quran, the ayat of Quran, and we want to use, how do we want to use in our treatment or in our daily seeing patient. So we can incorporate this in terms of the supportive psychotherapy using the Islamic approach. We can have CBT using Islamic approach, integration. We can use concept of psychotherapy. Some all are being put in such a way of integration. The way that we do it. Being a Muslim, actually, we have certain ways how to deal with all these difficulties. But to put it in a better and clearer, we bring some hadith, some sirah as well. So how and to whom that we shall give when we assess the patient religious and spiritual practice or belief. So the patient will probably will say, doktor jangan cakap saya jangan sabar. Saya dah sabar lama dah dengan panic disorder. So number one is we have to teach them to accept the symptoms is part of the disease. Then the next one is even if we are having cough and cold, heart attack, we always say this is a test from Allah. So what is more specific that in the surah that refers to certain emotional conditions, certain things? When Rasulullah SAW heard or received the ayat Iqra from Jibril, and the Quran said in the surah Al-Muddassir, seorang yang berselimut, satu lagi surah Muzammil, so Muddassir. So this is the two surah is referring to the anxiety that Rasulullah SAW have when the first thing that he has, ya ayyuhal muddassir tu, he received a first wahyu, Iqra, from Jibril in Hira, in the cave when he's alone. He felt so scared. And then when he was about to leave, he still heard the voice. So he went home with full of fear, anxious, sweating until the end that he entered the selimut. He covered himself under the blanket and he asked his wife. His wife come and hug him and put him at peace because it's a fearful experience. So from there, what did Allah said to him? Ya ayyuhal muddassir. Lagi? Kum fa'anzir. So, wahai orang yang berselimut, bangunlah. So if you follow that, it's wake up and pray. Wake up and pray. And then read Quran with tartil if you open that. So this is a thing that you can use whenever we want to tell the patient that this is a panic attack, anxiety, and we have a ways of dealing with it. We take a medicine and it's a temporary as well. So after that, Rasulullah SAW recovered. And we go back to Allah in terms of making dua, zikir, or remember Allah, but at the same time that we took medicine if it is prescribed. Sometimes it's a mild panic disorders, probably will not require medicine, but requires some behavior therapy. Okay. When this is one of the examples, so you can bring the tafsir, and what do you do to those patients who look at themselves as they use the religious coping in whatever they did. So then we just emphasize this when they got the panic disorder or acute stress. Okay. I'm interested in the first slide about Islamization, whereby it is told about being test, is it? Test ke? Some test. So everything is a test. Okay. Test you with something of fear and hunger, a loss of wealth and leaves and fruits. But give good tidings to the patient who, when disaster strike them, say, indeed we belong to Allah and indeed to Him, and we will return. So this is applicable for current situation, the pandemic. Surely we test with something of fear and hunger. People don't eat now. They lost job. Dah banyak food bank keluar. And a loss of wealth and leave. Yeah, we have to sell the house. We have to sell whatever we have. Fruits, but fruits so maybe symbolically about something nice, but give good tidings to the patient who, when disaster strikes them, say, indeed we belong to Allah, inna lillahi wa inna ilaihi raji'un. So this is one of the example that we can see that everything is a test. So we can give more example in terms of what sort of from the Sirah and the Hadith, and how this surah, how this ayat being said or being done to Rasulullah SAW, because all the ayat is the conversation between the Allah give to Rasulullah SAW. So there's much more that you can find. So if let's say we want to use all these ayat, all these ways, the patient, we have to also assess the patient's condition, the acceptance. Sometimes when we are too early in telling them, okay, sabarlah, this is ujian. So people say, you are joking because only me knows how is it. So it's that's the other issues, yeah. So normally we will say, let's talk about it. Let's accept the feeling. Jangan cepat-cepat nak kata kat dia sabar. So let us feel, because it's very normal to feel sad, anxious, and worry when we are having some musibah kan. Kita worry about now pun. Pandemic kita dapat ke kat kita semua. So let us feel that first. It's okay to feel several the acknowledging of the emotion, the validation of the emotion. And then we bring all the kisah-kisah that we want to share with the patient as a supportive element to give a positive mind for them, yeah. But honestly, whatever situation they have, we must acknowledge the emotional and the emotional difficulties that they are facing. So kena acknowledge lah. Takkan awak bela-bela apa semua dah, ni tak apa, it's gonna be alright. No, we never say that. We have to see that and do the assessment. Okay. So I guess we finish our seminar. Am I right? Okay, so thank you for all presenters. Now I have one more. Wait, tak ada battery, tak ada electric pula. Okay, we have I have one lecture with you all. When do you think that we can do that?
This Thursday, Prof. Is it okay?
Thursday afternoon cannot. Do you have anything on Wednesday to second day Raya lah? I'm not sure how do you all, are you celebrating Raya for these 2 days? Are you celebrating or not? Thursday is my clinic day in the morning. Afternoon I have a clinic I have a patient. So when do you think that you wanted to do? You want to do, let's see, tengok jap ya. You give me some tentative date. Bila ya?
Boleh, Prof. Friday, Prof. Friday. Okay, Prof.
Friday after Raya lah kan? I think I have something. It's gonna be like 1.5 hours lecture. If we can do Friday morning around 8 something.
Friday morning?
8:15, yeah.
Friday morning we have lecture at the morning.
Oh, you have lecture. Lecture apa?
Dissociative disorder with Dr. Nizam.
Oh, okay. Dissociative disorder. Okay, so when do you want to do? You mean Friday afternoon? Did you mean that?
Yes, maybe after 10.
I think I have class with postgraduate. Let us make Friday around after 10, is it? You mean we put that tentatively around 11 to 12:30. Is it okay?
Okay, Prof.
Unless some of you, are we allowed to go to, belum boleh solat lagi kan?
Belum.
Okay, we tentatively we make it at 11 to 12:30. Okay?
Okay, Prof.
Okay, thank you. So, Assalamualaikum. Thank you very much. And please send me your slide because we need to give marks for the presentation and the content. You can have you can send to my email. Okay? So, today is so tomorrow is Idil Adha. So, this is the time whereby many of people are waiting, and insyaAllah banyak-banyakkan bertakbir dan bertahmid. So hope you enjoy the 2 days off. 2 days, right? From tomorrow and Wednesday will be off from duty, from class. Betul?
Yep. Yes, Prof.
Okay. So thank you very much, and see you on Friday insyaAllah. Assalamualaikum.
Salam. Thank you, Prof.
Thank you, Prof.
Thank you, Prof.
Thank you, Prof.